What I'm going to talk about is the definition of balance and fall, the risk factors for fall, assessment tools to measure balance and predict fall, and prevention of fall. We know that the balance is the ability to maintain the line of gravity of the body within the base of support with minimum postural sway. And it is controlled by somatosensory inputs, visual inputs, vestibular inputs, which are actually then integrated centrally. And then there is muscle response, muscle strength, and range of motion. A fall is said to occur when an individual suddenly and unintentionally comes to rest on the ground or any lower level. And the recurrent fall is if you fall more than twice in 6 months. And then there is a near fall where a person slips, stumbles, or trips, but is able to regain control prior to falling. About one third of people more than 65 years or more than half over 80 years of age fall every year. 1 out of 5 will need medical attention and 1 out of 10 will sustain a fracture. And this is a leading cause of death. And of course, we know the statistics about the hip fractures. Now, in America, it is said that 1 out of 4 older Americans fall every year. So there's a fall every 20 minutes. 1 in 5 will lead to head injury or broken bones. And people who fall will have twice as much risk to fall again. And there's a tremendous cost. Why is fall important? Because it can lead to subdural hematoma, fracture, soft tissue injury, loss of function, mobility, independence, dignity, and confidence. And of course, there is a fear of another fall. And those who fall frequently have poorer outcomes. The worrying aspect is that the rate of fall associated with serious injuries is on the rise and maybe 100% higher by 2030. And as was said, in osteoporosis, the fracture occurs because of a combination of fragile bones and a fracture. And in this study, about half of the patients who were under treatment for osteoporosis had reduced physical activity because of a fracture along with the caused by a fall. Now, why do we fall? Because there's a change in sensory system, motor system, and the central sensory integration leading to balance impairment. And there are multifactorial and interacting causes. Intrinsic risk factors are like gait and balance impairment, peripheral neuropathy, vestibular dysfunction, muscle weakness, vision impairment, medical illness, advanced age, impaired activities of daily living, postural hypotension or orthostatic hypotension, dementia, and drugs. There are extrinsic risk factors like environmental hazards, poor footwear and restraints. And there are precipitating causes like trips and slips, drop attacks, syncope, dizziness, and acute medical illness. And balance disorder is common in community, as was suggested by this study, where 1 out of 3 elderly people had a problem with the balance. There's also something called post-fall anxiety syndrome, which occurred in more than 50% of the patients who had a hip fracture. And that is particularly common in those who live alone, who have cognitive impairment, balance and mobility impairment, as well as history of fall. And you are more likely to have a fear of fall if you're obese and have impaired mobility. We all are conversant with the gait cycle. However, what happens is that the gait becomes abnormal with age. About 15% individuals older than 65 have gait disorders, which increases to 35% for those above 70 years. And with advancing age, more and more people need walking aids. You must distinguish between fallers versus non-fallers. So if you fall once, that doesn't label you as a faller. A non-faller has got a different gait pattern, and that you can distinguish as is shown by these parameters, that the fallers have lower gait velocity and more variability of the steps, and they have a shorter stride as compared to non-fallers. So you can actually pick up those who are frequent fallers. This was also mentioned. The frailty is the decreased physiological reserve, decreased cognition, and decreased social function. And what happens is with age, with every stress, you are unable to come back to the same level of recovery as pre-morbid, and then eventually come to a state of dependence or disability. And sarcopenia was also mentioned by Dr. Wong. That is the age-associated loss of skeletal muscle mass and function. And that is diagnosed by a gait speed less than 1 meter per second and objectively measured low muscle mass using the DEXA. And that is, in men, it is less than 7.23 kilogram per meter square. And in women, it is 5.67 kilogram per meter square. You should suspect sarcopenia if somebody has normal gait speed, but low grip strength or low muscle mass, or if somebody has a low gait speed less than 0.8 meter per second and low muscle mass, then he is sarcopenic. Sarcopenia, along with physical frailty, is a part of general frailty, and which includes the cognition and other domains, and is responsible for fall, as was shown by this study among 847 Mexican Americans. So, how do you evaluate them? You inquire about any fall on difficulties with balance and gait. It's a multifactorial assessment, identification of risk factors, and targeted intervention. This book I wrote for Indian Society of Bone and Mineral Research, and in that it's a simple list about who is prone to fall. Those who have poor eyesight, those who have fallen previously, cannot stand on one leg, take long time to get up from the chair and walk, trip often or collide, take medicines which make you drowsy, have postural hypotension, which means blood pressure falls by more than 20 millimeter of mercury or falls below 90 millimeter of mercury on standing from lying position, and emotional or state of mind also contributes to the fall. And accordingly, we have advised one self-assessment to assess the balance. And one interesting thing about that is, which was described by Tinetti, is stops when he talks. So if a person is unable to keep on talking while walking, he's at high risk of fall. When you take a history for fall assessment, it must look into circumstance, the frequency, time, location, circumstances, surface, and obstacles, associated factors such as footwear, walking aids, glasses, substance, drugs, etc., associated symptoms like dizziness, vertigo, tinnitus, legs giving away, chronic problems like cardiovascular diseases, neurological diseases, the past history of falls, new symptoms. The drug history is extremely important because polypharmacy is a very important cause of fall. And then diuretics, analgesics, and alpha blockers, or those which are causing sedation, also predisposed to fall. And then, of course, you should ask about the functional status, whether the patient was ambulatory, indoor, outdoor, or without the support. The physical examination includes the sensory examination, cardiovascular examination, neurological, musculoskeletal, mobility evaluation, and assessment of balance and gait. The environment assessment is an important part. You must look at the lighting, walking surface, furniture, railing, clothing, equipment, etc., mental and affective testing, as well as lab and diagnostic testing for anemia, electrolyte imbalance, dehydration, arrhythmia, screening for osteoporosis, blood count, X-ray, and ECG. So this is the ABC of why older agents fall. That is age, ambulatory status, and assisted device use, balance, behavior at the time of fall, chronic conditions, cognitive defects, drugs, exercise level and environment, footwear, and flooring. And if you have greater number of risk factors, your risk of fall becomes greater. This is a very important test, which is called 30-second stare test. If you hold your hands across your chest and get up from the chair, you should be able to do it at least 14 times in 30 seconds. And if you have a below average score, it indicates a risk for fall. Another test is the functional reach test. You stand with your feet shoulder distance apart, and then you try to reach out without losing your balance or without swaying. And if you are not able to reach 7 inches, that is highly predictive of falls in older people. Another very important test is the floor transfer test, moving from standing to sitting on a floor mat or back to standing. It's measured in seconds. Then there are special clinical tests like timed up and go test, Berg balance scale, performance oriented mobility assessment, clinical tests of sensory integration for balance. And this is a timed up and go test, which is actually one of the most useful and easy to do tests. The patient are asked to get up from the chair, walk for 3 meters, make a 180-degree turn, return to chair and sit down, and they are allowed to use their walking aid. It is normal if they can do it within 10 seconds, abnormal if they take more than 14 seconds, and if they take more than 20 seconds, they have severe gait impairment, and that's a very sensitive and specific test. Berg balance test looks at the balance between the sitting position, standing position, and the dynamic balance. And in this list of all the tests which can be done, you will realize that the Berg balance test and the timed up and go test are highly sensitive and specific and can be routinely employed. We have this balance master, which is an equipment which is able to assess fall risk, postural stability, clinical sensory integration, balance testing, and balance training also. So you have these footprints where you're supposed to stand, and then this is able to rock in different directions, measure the pressure which the foot is exerting onto the platform, and give readings. And then we have a gait lab, which is actually also able to capture the gait pattern. So you can look at the step length, stride length, etc. The most important thing is that if you have instituted some intervention, like some exercises and all, it can objectively tell you whether the patient's gait is improving or not, and actually can help you for a very good feedback or validation of your intervention. Fall prevention is extremely important. Falls are highly preventable. We can do a lot to prevent it. This is mostly multifactorial intervention which helps, which involves strength and balance training, home hazard assessment and intervention, vision assessment and referral, medication review, and the exercise interventions are mainly the strengthening, endurance, and flexibility exercises. And if you can strengthen the lower limb and core muscles in 2 to 3 sets of 10 to 12 reps of each muscle group, that on twice a week on non-consecutive days. And similarly, the flexibility exercises can also be recommended twice a week. So these are some of the exercises to reduce your risk of falling. You can do this with the support of chair, and then you can also do them by putting pillows under the feet, and then you can use the physio ball. The balance exercises have been recommended by Mayo Clinic as well. The yoga helps you maintain your balance. Tai Chi is a very useful thing. There can be task-oriented motor learning exercises like stepping forward and across, walking, at a certain speed, and then changing directions while walking an oval path and all. So this is an example which we use in our sitting. You can ask the patient to move along those tracks and while maintaining the balance in order to improve their balance. And it has been shown that these programs reduce the number of falls, and this is the best technique. And exercises which work best are those which challenge the balance, use higher dose of exercise, and walking is not really a great exercise for preventing fall. The assistive devices are extremely useful. They actually broaden the base of the support, and if your patient is at a high risk of fall, it is better to advise them assistive devices. There are these walking sticks available with alarm if in case there's an irregular surface there, and the hip protector, one of which has been designed by us, which can prevent a fracture after the fall. There are cutting edge concepts and practice available. There are new technologies and computer assisted balance boards and posturography, virtual reality, and some games and balance whiz which can help prevent the falls. This is an example of balance training by Biodex, which allows weight training, postural stability training, maze control training, and random control training. So this is a typical screen where you can show that how much load the patient is putting on each side, and he can be trained to shift the weight, and that way he can actually keep on improving his balance. This is a maze control training where the patient can shift his balance to actually hit the targets sequentially one by one, learns to control his body better and get better results. And then of course there's random control training like this. There are games which are called exer games, which are exercise based video games. They can improve the physical balance and strength and cognitive function, and then they are available by V also. There's something called volitional step training, which involves rapid and accurate steps in multiple directions, which can reduce falls by 50%. There's another step you can see. There is a support or harness for the patient. The patient is exposed to repeated slips or trips to generate rapid balance response, and it also reduces the falls by 48%. We started this facility. This is a newspaper cutting in the local language, but this is called Sathi, S-A-T-H-I. Sathi means a companion in our local language, but it is a Save the Hip initiative. And there we have this balance master and all these wobble board exercises and the trampoline exercises. We know there are certain drug interventions which can help, like vitamin D, the deficiency of which gives rise to reduced muscle mass, weakness, slow reaction time, and increased risk of falling. And we know that the monthly dose of vitamin D can prevent fall. Myostatin antibody, which myostatin inhibits skeletal muscle growth. So myostatin antibody has been shown to increase lean mass and improve the muscle power. Similarly, single dose of methylphenidate has been shown to have a better postural stability. In patients with Parkinson's disease, rivastigmine has been used for the balance testing. Of course, you have to spot the hazards Yeah, as was told by the previous speaker, you can actually, you should remove all loose rug and loose cables. You do a brown bag review. Look at what medicines the patient is taking and take out the unnecessary medicine. Have vision and hearing examination every year. Keep everything within reach so that the patient doesn't have to extend too far up and too far low. And of course, give them walking support, particularly if a patient feels orthostatic hypotension, which means get head rushes head rushes when these stands too quickly. Teach them to rise slowly and count up to 5. No loose rugs, no loose wires. The steps should be safe and adequately lit, and there should be a railing, and there should be all attempts to prevent fall. The clothes and slippers should be friendly and not make you fall. And then bathroom is a big offender. Add grab rails to shower walls. Use a bath chair and handheld shower, and use non-slip tub mats. And there are certain community-based programs which essentially mean add screening tools, perform balance exercises, give adequate vitamin D at community level, strengthen the muscle, cognitive behavioral training, educational sessions, popularize hip protectors, and identify people who are at risk of osteoporosis and advise them on fall prevention and promote a healthy and active lifestyle. So to conclude, falls are common in elderly and may lead to injuries and decline in function. Evaluation should include the risk factor assessment, balance and gait assessment, and of course the home assessment also. Exercises improve the outcomes. Injury prevention is an important goal in the population, and your treatment must be individualized. Thank you very much for your attention.